Okay, so now we're going to go into coronary artery disease. So coronary artery disease is caused by this atherosclerosis. And so I thought this was funny. It came from your book. So atherosclerosis comes from the Greek word ather, which is fatty mush, and sclerose, which is hard. So atherosclerosis is hard, fatty mush. It's these soft deposits of fat that harden with age. And you eventually get hardening of the vessels themselves, hardening of the arteries. And so what the initial step to this is generally endothelial damage. And so we talked about that endothelial, that's that single cell layer on the inside of the vessel can get damaged. And it develops atherosclerosis from there. So generally, if the endothelium is healthy, it's not reacting to platelets or coagulation. It's when it has these little damages on that single cell layer that's when the platelets and the coagulation and stuff can kind of latch on and start developing these deposits. And so you can have chronic endothelial injury. So high blood pressure, like we just talked about, can damage the vessels. Smoking, high cholesterol, diabetes, certain infections or toxins, sepsis can definitely damage the endothelium. And so coronary artery disease in particular is when the coronary arteries themselves start to get this atherosclerosis. And so our coronary arteries are the vessels that sit on the outside of the heart, and they supply the heart tissue with blood supply, right? Because the heart doesn't get oxygen from the blood it's pumping. It gets oxygen from its own blood supply, which is from the coronary arteries. And so it depends on the patient themselves. So when they start to get this buildup of atherosclerosis here, the body will start to create this collateral circulation in the coronary arteries. It'll start to build its own little vessels that go around the blockage. Because our fatty streaks in the coronary arteries can be seen by the age of 20 in our patients. Whereas our fibrous plaques, we can start seeing as early as age 30, and then it increases with age. And so that's when collagen will cover those fatty streaks and form a hard plaque. And then we get a complicated lesion when we have that further narrowing or a complete occlusion of the vessel itself. And so this collateral circulation takes time to build. So if we have a complete occlusion and it's quick, then the patient might not have developed this collateral circulation in time. And so if you have a sudden clot or something or a sudden spasm, that's when you're going to start having like a heart attack to the actual heart tissue itself. You're not getting circulation. So our risk factors for coronary artery disease, again, we have our non-modifiable versus our modifiable. So our age, gender, ethnicity, and genetics are not modifiable. Men over the age of 45 and women over the age of 55 have your highest incidence. The 10-year difference is usually related to hormones. So like once women have gone through menopause, then they're at just as much of an increased risk of coronary artery disease as men. And women are actually more likely to have comorbidities and die after their first myocardial infarction. So as much as we like to say men are at increased risk, heart disease kills 10 times more women than breast cancer, and it's the leading cause of death for women. And it's because symptoms for women can be rather unspecific. So we'll kind of get into that when we get into our symptoms here. And so our modifiable risk factors, these are the ones we actually do want to go for, right? So our high cholesterol, hypertension can cause that stress to the endothelium. and increase the risk for atherosclerosis. So can smoking, physical inactivity, obesity, diabetes, high stress lifestyle, and then substance use. So the big substances that we watch out for with coronary artery disease are stimulants. So cocaine, meth, that sort of thing can cause a myocardial infarction just on their own, taking those stimulants. So to treat coronary artery disease, we can use those lifestyle modifications, the AHA's Life Simple 7, like we talked about with hypertension, but we also use drug therapy. So statins are the most widely used. Those are our lipid lowerings. They inhibit the production of cholesterol. And then the other thing we'll usually put these patients on is an antiplatelet. So low-dose aspirin is usually first choice, and then Plavix if the patient can't tolerate that aspirin. Angina is chest pain. And so that's generally one of the symptoms that the patients will get with coronary artery disease. It's from this myocardial ischemia, so they're not getting as much oxygen to the tissue as they should be. And so they have that atherosclerosis in the coronary arteries, and they're not getting as much blood flow or oxygen to the tissue that it needs to. There's both chronic stable angina and then unstable angina. So unstable tends to be that acute, chronic versus acute. It's generally the difference between just ischemia, that chronic stable ischemia where we're not getting that much oxygen, but we're still getting some, versus a myocardial infarction where we're not getting any oxygen and we're infarcting the tissues, where the tissue is actually dying. And so we want to do a thorough pain assessment on our patients. And so you'll see some of these more common areas that patients can get chest pain. So mid-sternum, substernal, can radiate up to the neck or the jaw, can be epigastric, again, radiates to the neck or the jaw, or kind of between the shoulder blades are some of the more common sites that you will get that chest pain. Now, like I was talking about with women tend to not have these specific symptoms. It's usually more, I don't feel very good, or indigestion. It's very non-specific when it comes to women. And so that's why we can not catch it as easily as we can with men sometimes. So that's why we want to do a thorough pain assessment. And then the other thing is, for both men and women, they may not describe this as pain. They might describe it as a heaviness to their chest, like somebody's sitting on their chest, or a tightness to their chest. Diagnostic tests for angina we're going to be ruling out whether this is a chronic stable or an unstable MI that's happening. And so we want to do a 12-lead EKG. Cardiac biomarkers are going to be like your troponin test. And we want to do a lipid panel and a CRP. We want to do a chest x-ray. And then we may get also to an echocardiogram or a stress test. So if your cardiac markers, your troponin level, and your EKG are negative for an MI, then we're going to head to the stressed echocardiogram. If our cardiac markers, if our troponin and our EKG show that the patient is having an MI, then we're actually going to go to cath lab, and we'll get into that a little bit later for our treatment for that. And so the echocardiogram is an ultrasound of the heart, and a stress test is a stress echocardiogram. So we have to stress the heart out and then look at it on ultrasound while it's stressed. So an exercise stress test is usually the most common. That's the one where the patient will get on the treadmill to start stressing their heart out. But let's say the patient is wheelchair bound, or they're very weak, or they're a fall risk. There's actually medications that we can inject into the patient to elicit stress to the heart without requiring physical activity. And so the drugs that we use for coronary artery disease depends on some of the symptoms that we're having. So nitrates help with that chest pain. And so the sublingual nitro, there's usually a tab or a spray that the patients will use. It helps decrease the preload of the heart. It dilates out the veins. The big thing is, when it comes to nitrates, is it can cause a huge drop in blood pressure. And this is especially true if they are taking medications for erectile dysfunction. So Cialis, Viagra, those medications are contraindicated when it comes to taking nitrates within the past 24 to 48 hours. So they can't have had either of those medications. So that's an important thing to ask your patient. So when they take this nitro, it's 1 tab or spray every 5 minutes, up to 3 doses until the symptoms resolve. So if 1 tab resolves their symptoms, great, they don't need to take any more. But if they're still having chest pain after the first tab, then they'll take another one. And again, they'll take that up to 3 times. And if the symptoms haven't improved or resolved within those 3 doses, they need to call 911. And that's what we're teaching our patients. And so because it dilates all the vessels, it can cause a few side effects. It can cause that huge drop in blood pressure, and so the patients can get dizzy. The other thing is it usually causes a pretty wicked headache, and that's again because it's dilating all those vessels out, so you're getting that kind of rush of blood into the brain, and so they get a pretty wicked headache on this medication as well. And the other thing is patients can take nitrates prophylactically. So if they're going to go do something that generally would cause chest pain, like if they're going to go out for a walk, or, if they're doing physical activity that normally would cause chest pain, the patients can take a nitrate tab or spray before they do this. Or sex is another big one too. So if the patients are known for getting chest pain during physical activity and they want to have sex, they can take a nitro or a nitrate tab before the sex to help with that cardiac chest pain. They just can't also be on that erectile dysfunction medication. Other medications we use for coronary artery disease are beta blockers, because this helps reduce the rate of the heart, and so it reduces that cardiac work. And then calcium channel blockers help to dilate out the arteries and decrease afterload. So cardiac catheterization, that's when I was talking about cath lab for our patients. So this could be done acutely if our patient is having an acute MI, or this could be done for our patients who might not have a full blockage, but they have a pretty big blockage and they're getting chronic chest pain and it's getting worse. Then they can have an outpatient cardiac catheterization process. And so they go through the femoral or radial arteries, so either like in that hip area or in the wrist area. And the doc will put like a sheath into the artery itself, and they put these little catheter equipment that goes all the way up to the cardiac vessels, the coronary arteries. So it goes all the way up the wrist, through that artery, up to the coronary arteries themselves. And then at the end of these little catheters that they have, the end of these little tools, they have little stents that are ready to go. And so you'll see this is the stent that went through the vessel just fine. And then they'll use a balloon to blow that stent up. And then they remove the balloon afterwards, and that stent stays in place. And so this is a cardiac stent. This is a stent that's in one of the coronary arteries. It's like a little cage that helps keep that vessel open. The other process that doctors can use is they could do a CABG or a coronary artery bypass graft. And so this is when they'll take a vessel, usually from the leg. They'll take some vasculature from the leg, and then they'll attach it past that blockage. So they're going past this blockage here, and now there's some vasculature that goes to the rest of the vessels here. Same with over here. They could have taken an artery from somewhere else, and so this is a mammary artery. It looks like it would go to the breasts, and so they would remove it going to the breasts and then push it past this blockage on the coronary, on the heart itself. This is an open heart surgery. This is definitely not open. This is definitely not outpatient. This is something where the patient's chest has been pried open and they have a lot of risk factors after a procedure like this. So they'll be in the ICU for a few days as they get better. That's all I have for coronary artery disease. In the next video, we're going to get into heart failure.